I will talk about the approach to complex PCI. I will focus on when to use LV support mainly in left main PCI, and I will describe the approach to distal left main bifurcation techniques, including stenting strategy. LV support mainly applies to left main PCI. It may occasionally apply to multivessel CAD or proximal LAD PCI in the setting, particularly of cardiogenic shock, but I mainly consider LV support in a subset of distal left main PCI. So I will go over the criteria that I use to decide when to use LV support. You can find a lot of algorithm online, a chip algorithm. I will be more specific. I will give you specific criteria. There are top 2 factors I consider when I decide about LV support during PCI, and there are 6 other factors, less important, but important as well. So the top 2 factors I consider are, number 1, and the most important factor is baseline hemodynamics. And those are multifold. So 1, the clinical hemodynamics, low or borderline blood pressure, less than 90/100 systolic pressure, sinus tachycardia, especially heart rate to blood pressure ratio over 1. So those are clinical. Clinical heart failure, pulmonary edema, orthopnea at the bedside. You make the patient lie for 1 minute, and you see whether he gets subjectively dyspneic and whether his O2 sat declines, at least 1 minute of lying supine. Hypoxemia that is due to heart failure, that is more severe than a baseline in a patient who's chronically requiring O2. So even hypoxemia is extremely important to me, requiring O2. So I look at those, then the invasive hemodynamic, particularly the LVDP that we get during our diagnostic angiogram. Over 25 is worrisome. 16 to 25 is borderline, but over 25, especially over 30, is particularly worrisome for hemodynamic decompensation during PCI. Cardiac index less than 1.5, 1.8, and more advanced feature, PA-SAT less than 50% or full-blown shock with elevated lactate. I take into account the presence of multiple of those. Evidently, if you have a blood pressure of 90, but none of the rest, that is not concerning at all. But having a combination of multiple of those is what pushes me to use hemodynamic support during PCI. Also, the severity of each. Is the blood pressure 95 or is it full-blown less than 90? So they have to be multiple, and I account for the severity of each. And generally, when I have multiple of those and severe, mainly in the setting of left main PCI, this is when I consider LV support. I also take into account the second big feature, complexity and length of left main PCI. And there are 2 big things that make the left main PCI more complex. The need for calcium modification, whether atherectomy or lithotripsy, and the need to use a planned 2-stent strategy, particularly the complex 2-stent strategy like DK crush or Culotte, that involve multiple lengthy stents and multiple 2 recrossing of stented area with wires. So versus a much shorter provisional stenting or T or TAP technique for dual stenting. Okay, in fact, you can modify your strategy if you decide I cannot or I don't want to use support, I want to keep it simple, then you can steer away from those and focus on provisional stenting or T or TAP, which I will describe later. So I said I mainly use those in left main PCI. In non-left main PCI, I consider LV support if I have full-blown cardiogenic shock and I think the procedure will be lengthy, or if I have complex and long PCI of the last functional territory. For example, PCI of a proximal long and calcified RCA or long and calcified dominant circumflex in a patient with extensive anterior akinesis and EF 20%. He's relying on that RCA or on that left circumflex to supply his functional myocardium, his remaining functional myocardium. So those can be treated with LV support, particularly if you have bad hemodynamics. So usually, when do I do LV support? If I have the combination of those 2, Bad hemodynamics, mainly a combination of multiple of those, clinical and invasive, plus complex and long left main. So when I have the two, I definitely use LV support. When I have only one of them, then it depends. If it is hemodynamics, I account for how bad it is and how many factors and how severe they are before I decide about using LV support. And I also account, when only one of those is present, I account for the 6 additional features that I will describe. But very importantly, those 2 factors are not static, and that's a key idea. It's not that I see bad hemodynamics, I say, okay, we do need to use LV support. No, I keep in mind that both those factors are modifiable. And here's what I mean. First, I want to show you what in bad hemodynamics, this is one feature. You have a shrinking on the LV pressure, shrinking systolic pressure, and rising LV diastolic pressure. This is what you call a shrinking ventricular waveform. It's very concerning. When I see this, I'm very concerned that the patient is going to go in full-blown shock if he's not already, and PCI will put him there if I don't use support. Also, the same shrunken aortic pressure with narrow pulse pressure in conjunction with that shrunken LV waveform. So here's what I mean by saying that those hemodynamic factors are modifiable. So hemodynamics are not static. If I don't absolutely have to do the PCI now, and I have those bad hemodynamics, it's far better to stabilize the patient and bring him back for PCI. He's far more likely to tolerate it. So one, if you have failure, well, diurese the patient, then bring back for PCI. If you have full-blown shock, but no ongoing ST elevation or profound ST depression, and the key word here, ongoing. So if you have no ongoing ST elevation or profound ST depression, don't intervene yet. Place support device, balloon pump or Impella if needed. Then depending on the severity, bring back for PCI once tissue perfusion and hemodynamics have improved. So the only time you need to intervene in the midst of bad hemodynamics is if you have full-blown shock and ongoing profound ST abnormality. This is when I place support device, typically Impella CP, then I do PCI emergently. So oftentimes you can stabilize and improve hemodynamics before your PCI unless full-blown shock with ongoing profound type 1 MI and profound EKG abnormality. Concerning the second big factor, again, as I said, in a patient with complex distal left main, but not candidate for Impella support because of vascular issues or high bleeding risk concern, plan for provisional strategy and accept a suboptimal result across the ostial left circumflex. So plan for 1 stent with provisional 2 stent. Or if you do 2 stent, if you plan on doing a 2 stent strategy, do a TAP strategy, which is simpler than DK crush and Culotte and involves less steps. Also in that case, do shorter balloon inflations. Be aware of your pressure. You will see your pressure immediately collapse as you're inflating the balloon. So keep your balloon inflations 10 seconds or less. Do short rotablation runs of no more than 10 seconds with a lot of time for recovery between runs. No rush. Same with lithotripsy balloons. Keep the inflation shorts with a lot of recovery times. So you can modify the way you do things. And as I will explain, there is good data showing you, even in distal true left main bifurcation, provisional stenting is appropriate and is often as good as a 2 stent strategy, as has been shown in EBC main trial. And when you do use a 2 stent strategy, I'll show you that a lot of trials use the simple T or TAP, which I will describe later in the talk. Now, there are 6 other factors I take into account. One of them is EF. So notice EF is not my focus. A lot of people focus on EF to decide about support. No, that's not the greatest factor to look for. Low EF with a stable hemodynamics is not a major factor, as it implies when your hemodynamics are stable that the LV, LA, and the peripheral tissues have adjusted to the impaired myocardial function. Still, the limited functional myocardial mass reduces your tolerance to ischemia, but it's not a major factor. Another thing, in the same category as low EF is if you have severe AS. Again, if your hemodynamics are stable, this is not a major factor. Now, another factor is left main with diseased RCA. So you have severe left main, but you also have a diseased RCA. That will increase your procedural risk. This does not mean, however, that RCA PCI should be done before left main PCI, as used to be said. In fact, it's often best to start with left main PCI as per the Excel trial, the most important left main trial. They recommended starting with left main PCI in patients who also have a concomitant RCA disease. They only recommended starting with RCA PCI, and that's what I do, if it is large, that RCA, and critical, super dominant, large, and critical disease over 90%, and it's perceived to be the culprit of an acute presentation such as MI, while the left main is relatively moderate compared to that RCA. This is the only time where I would start with the RCA PCI. Nonetheless, you start with the left main, but that will be associated with an increased risk. The third feature, an extremely important feature, having to do distal PCI in the LAD or the left circumflex through a diseased ostial left main with guide ventricularization. There is nothing worse in PCI than left main guide ventricularization. Whenever you see your left guide ventricularizing in the left main, you should try to disengage, and you should absolutely limit the periods of guide ventricularization in the left main. Guide ventricularization means you're having left main ischemia, ongoing left main ischemia. And if you don't pay attention to it, I can guarantee to you, in a long case with a left main ventricularized, your patient will crash at the end of the case. So you're not going to tolerate left main ventricularization for several minutes. So you keep that very brief for a few seconds at a time. And here's the idea. And when does this happen? It's easy to intervene on ostial left main because you keep your engagement very brief during ostial left main, and ostial left main stenting is usually a simple and quick procedure. It's easy to intervene on ostial left main. It's much harder to intervene through a disease ostial left main on more distal disease, because in that case you need longer catheter seating in that left main, and you need that guide to be engaged in order to deliver wires and stent, which at times in calcified patient can be difficult. So you end up seating that guide in the left main for prolonged periods of time potentially, and that can cause prolonged guide ventricularization in that case and prolonged ischemia. That's why when you have to intervene on a distal disease while having guide ventricularization with significant left main disease, one, you try to stay disengaged as much as possible. Two, if the left main is significant, stent the left main first in those cases, then stent distally later after you've opened channel here for your guide to sit while you're delivering your devices distally. Okay, so key idea, if you expect though for whatever reason that you will have guide ventricularization off and on during your case, you may consider, that's an extra reason to consider LV support, but the first thing to consider is limit my left main ventricularization and fix the left main first if it is significant. Because even with LV support, guide ventricularization is a horrible thing and your patient will crash even if you have Impella. The fourth factor out of those six that I mentioned is anesthesia. Anesthesia by itself can worsen your hemodynamic compromise. In that order, the best tolerated is moderate sedation. Then you have deep sedation with MAC anesthesia, monitored anesthesia support. And the highest hemodynamic compromise is when you use intubation with deeper sedation. In most of those complex cases, I try to favor that second one. So we try deep sedation using IV Precedex drip, for example, with high flow oxygen and with anesthesia support and monitoring. I have an anesthesiologist or an anesthesia NP with me in the room. They monitor the airways and the oxygenation. So I prefer that rather than intubation with deeper sedation, which will cause more hemodynamic compromise. And here's the thing about anesthesia. When do you get support, anesthesia support in complex PCI? That's often a question in your planning for complex left main PCI in particular. In patient with impaired baseline hemodynamics or oxygenation, I expect worsening of hemodynamics and oxygenation during the procedure. So in those cases, I consult anesthesia to help me in the case with the airway. Or the hemodynamics are okay, but the patient is old or demented. He would get agitated and confused in a long, complex procedure. So I get anesthesia support in that case. And what I do expect from anesthesia in those cases is this: deep sedation with high flow O2 or very high flow O2 without intubation and without the deeper sedation of intubation. So that second one, that's what I go for. And I get anesthesia to help me with that and to help me with monitoring in those two cases. So a fifth feature I look at, and a very important feature also to understand, PCI on a territory that's already akinetic is actually very well tolerated. So that steers me away from hemodynamic support. So not all low EF interventions are the same. If I do PCI on a mid-LAD in a patient with an akinetic anterior wall, this PCI is very well tolerated because the anterior wall is already akinetic, that it's not contributing to myocardial contractility already. So they tolerate ischemia very well in that territory, prolonged ischemic time. Conversely, in that very same patient, if you have to intervene before the first septal, he's going to tolerate any balloon inflation here, any ischemic time very poorly, because they tend to have hypercontractile segment at the base before the first septal that compensates for the rest. And this is what's keeping their cardiac output. So they tolerate very poorly balloon inflation and ischemic time and guideliner placement in that area. So we keep those very brief. Short balloon inflation and have a preemptively phenylephrine ready, knowing that they may collapse their pressure during ischemic time in that area. And I would say that in general, give you a general idea, even outside low EF, occlusion of the LAD before versus after the first septal makes a dramatic difference. I tell fellows, the first septal is king, always respected. Am I maneuvering before or after the first septal? S1, that first large septal, supplies the base of the heart and may prevent shock. That's why if you have an anterior MI with an occlusion past the first septal, cardiogenic shock is uncommon. Before the first septal, this is where cardiogenic shock is much more common. So that's why not all low EF are the same. So in a patient on whom you're fixing the left main and you're fixing the LAD as well, know that he's going to tolerate rotablation and balloon inflation in this area. So you can spend a little more time here, but you keep your maneuvers very short here. So know which maneuvers where will cause more hemodynamic compromise as you're doing your procedure and you're planning it. So that was the fifth point. So if you have multi-vessel PCI, it's nice to start actually with the akinetic vessel, which is the best tolerated, then fix the non-akinetic ones later on, because those will be poorly tolerated. So if you have, mid-LAD and proximal RCA and the anterior wall is akinetic, fix the mid-LAD first, then fix the proximal RCA. Similarly to that idea, PCI on a subtotally or totally occluded artery, antegrade fixing of that artery is well tolerated. So PCI on a subtotally occluded artery with good collateral, especially grade 3 collaterals, is often well tolerated because the patient is already at baseline tolerating poor flow in that territory. Okay. The sixth idea is PAD and femoral iliac disease. That's to decide whether I can put LV support, whether Impella or balloon pump. Femoral size, less than 5 millimeter, steers me away from support. Heavy calcium and tortuosity in the femoral iliac vessels also steers me away from support device. So one question that comes up, should you assess the peripheral vasculature before you do support? Frequently, yes, but keep it simple. You don't have to get a CTA on everybody like they do in TAVR. So one, go by physical exam. If you had good femoral pulses and you have palpable distal PT or DP pulses, you're often okay. I still favor doing some sort of non-invasive assessment, but you're usually okay if you have good femoral pulse and good distal pulses. Now, if you do or you don't, what is the assessment of the peripheral vasculature I like to do? The simplest one is when you're doing your diagnostic angiogram in non-emergent cases, and as you're planning, I will bring the patient back for a complex PCI with or without support. Then I try to do a low contrast aortoiliac on angiogram with just 15 milliliters, or better CO2 angiography with absolutely no dye for the aortoiliac angiogram, especially in patients with CKD. That should be available in all high complexity labs, CO2 angiography. Alternatively, if this has not been done, the patient is referred to you after diagnostic angiogram and this has not been done, you can do ABIs and non-contrast CT of the abdomen and pelvis. ABI will tell you the severity of PAD. As long as it is over 0.7, I'm okay. And non-contrast CT of the abdomen and pelvis. The reason here, it's not going to show you stenosis, but it will show me the amount of calcium and tortuosity that I will have to deal with if I'm trying to put Impella. I reserve contrast CT for severely reduced ABI, definitely less than 0.5, maybe 0.5 to 0.7 with no femoral pulses. Okay. So those are the 6 additional features I consider: low EF, diseased RCA, having to have guide ventricularization in the left main, which you should absolutely avoid regardless. The degree of anesthesia support that I need, and I try to keep it in the middle, deep sedation with MAC. PCI on a territory that's already akinetic or an artery that's subtotally occluded with collaterals, and the degree of PAD and the amount of calcium and tortuosity. Another idea I account for, if I say I'm going to need support, but I'm debating between balloon pump versus Impella. Another idea I account for is whether I can do single axis 14 French sheath with Impella. If I can do single axis 14 French sheath where I put the guide and the Impella through that sheath, then I may favor Impella over balloon pump, because in balloon pump I will need 2 sites of 7 to 8 French. So I'm not sure having 1 14 French access versus 2 7 8 French sheath, which one is worse. But in that case, I may favor the 1 single access 14 French Impella. And just to remind you how this works, remember, Impella motor is 14 French, but the catheter itself is 9 French. So you put a 14 French sheath and the Impella catheter is 9 French, you can put at the side of it a 7 French sheath. Typically a Terumo destination sheath, a slippery sheath, 45 centimeters. The problem is that those sheaths usually cannot push them all the way in. You'll have a piece hanging out, and that piece hanging out will make your guide longer on the outside of the body. So if your patient is medium height, you often cannot get the guide to properly engage the coronary. Another thing is, regardless of height, if you have a lot of aortoiliac tortuosity, then it's hard to seat those 2 catheters side by side in the aortoiliac and navigate the aortoiliac with both catheters, whether you're using a long Impella sheath or you're using the short Impella sheath. So consider those 2. You can usually put single axis in patients who are usually less than 5'7" or so, with no heavily calcified aortoiliac tortuosity. Putting the long Impella sheath doesn't necessarily help, because that long Impella sheath in tortuous and calcified aortoiliac arteries can get kinked and can make it hard to put another sheath next to it. So I consider aortoiliac calcified tortuosity, and I consider the height of the patient. Other questions regarding access: we generally prefer 7 French guide instead of 6 French. 1, because it provides more support, and 2, because in distal left main stenting, you may need to do simultaneous stent and balloon inflations 3.5 millimeter or more in diameter, especially with the tap and T techniques that I will describe a little later. Sequential crush, DK crush, and culotte may be done through 6 French. Another question is radial versus femoral access. Femoral access provides more support, which is valuable in complex cases, and a lot of operators prefer femoral access in left main PCI. However, radial is appropriate, and I use it. In those cases, I would put a 7 French radial slender sheath with 7 French guide through it. This way, if you need LV support, you are only using 1 groin access rather than 2. This idea becomes less important if you are planning on using Impella for hemodynamic and complexity reason, and if you think that you can use single access Impella. Another idea regarding radial access: account for your skill level with radial and with complex PCI in general. Early in your career, tend to use femoral access for your complex PCI, then progressively try to switch to radial access. Also account for the amount of tortuosity and difficulty you have encountered during your radial diagnostic angiogram. Another idea: if I've decided not to use support, as I frequently do in those complex cases, I always have phenylephrine boluses ready outside the cart, so the nurse is ready to give them as needed. And I use them as needed for mild hypotension to avoid the vicious circle of myocardial ischemia and worsening hypotension. You can also have a norepinephrine small dose drip on standby. There is no evidence that a support device is better than those intermittent and brief small doses of inopressor during the procedure. Another idea I mentioned earlier: shock from cardiomyopathy with severe left main and 3-vessel CAD, but no ongoing type 1 MI, no profound persistent ST elevation or depression, does not require immediate PCI. Rather, diurese and optimize the patient before PCI to reduce LVDP, raise systolic blood pressure, go from a shrunk LV to a more elongated LV waveform, then bring the patient back for PCI. In that case, the left main 3-vessel CAD is chronic, causing chronic cardiomyopathy, which decompensated with additional trigger. It could be AFib, it could be volume overload, it could be salt non-compliance, it could be transient ischemia, but it's not ongoing ischemia that warrants you to jump in the midst of the full-blown shock. So you can improve the patient and bring back. The only time you need to intervene in the midst of shock, like I said, is acute MI shock. And in that case, try to be brief and only treat what is strictly necessary, as culprit shock trial has shown. In fact, I will extrapolate that idea to cases where the patient is tenuous but is not in full-blown shock, and he's having an ongoing MI. So I'm doing PCI in a tenuous patient. In those patients, try to be quick and try to be focused, fix only the culprit and bring back for the rest once he's stabilized. The spirit of culprit shock trial is that the sicker the patient is, the more limited your PCI should be. So in full-blown shock, yes, you have to intervene in the midst of the shock, but try to be quick. And that applies to sicker patient, even if it's not in full-blown shock. You know, bad hemodynamic without full-blown shock. He's hypoxic, his LVDP is high, his systolic blood pressure is soft, without having full-blown shock yet, be quick and fix the culprit, only then bring back for more comprehensive revascularization. Another idea here I want to mention, I describe my approach. Eventually, everybody should also consider his personal expertise and the expertise of his cath lab. So consider operator and cath lab staff comfort and expertise in complex cases and in deploying support devices quickly. You have lower expertise, lower volume center. Most likely you will have a longer ischemic time during your manipulation and longer bailout times if you get a complication. So use support devices more readily in those cases. So it's okay to use them more often when you have less comfort level, but as you get more comfortable, you can start using them less often. So there is subjectivity involved in that. So I discussed LV support based on those 2 major features and the 6 additional ones. There are 5 major questions you ask yourself when you're doing left main PCI. That's one of them, LV support. There are 4 other questions that impact the idea of LV support. And the 4 other questions are, every time you see left main, as you're planning it, you're viewing those 5 ideas. So 1, need for atherectomy, rotational or orbital atherectomy, and or lithotripsy balloon. That will add to your complexity, but I decide to do that when I have heavy calcium. Frequently, that means seeing calcium on both edges of the vessel in at least one view. But, you know, there is subjectivity involved in that. If you do IVUS beforehand, after a small pressure balloon of the left main, or if the left main is not critical and you do IVUS, having an arc of calcium over 180 degree also can push you toward atherectomy and lithotripsy balloon. What left main bifurcation technique will you use? And I will describe that in a little bit. Is there distal disease in the LAD and circumflex that needs to be treated? And again here, try to limit and simplify distal disease treatment. Maybe bring the patient back later if his hemodynamics are tenuous and you don't want to decompensate him. There is this myth of complete revascularization, which has only been shown to be useful in MI setting, and it doesn't have to be done in the same procedure. Outside that, in a stable CAD setting, it is a myth that you should always do complete revascularization. That is based on retrospective data showing that complete is superior to incomplete revascularization. But this is likely because incomplete revascularized patients have more extensive and diffuse disease, which drives their poor outcomes, not the lack of full PCI revascularization. Also, you know, you can always stage it. Try not to do too much so you can limit your ischemic time, especially if you don't want to do LV support. So the other feature is LV support, which is influenced by those other features, as I explained, the 2 major and the 6 additional. Then the sedation plan that I'm going to use in this patient, which will also influence what LV support you use. And in general, again, I favor anesthesia for impaired hemodynamics or long cases in old, demented, confused patient, and I favor deep sedation with high flow O2. I take into account whether RCA is stenosed, as I said, although RCA PCI is usually done after left main PCI, unless critical large RCA with moderate left main stenosis. And when downstream disease is deemed necessary, we usually stent it before stenting left main, unless you have a critical ostial left main with guide ventricularization ischemia, which you should avoid at all costs. Now, why do we need to be selective in using LV support? Because there is no randomized data that supports the value of using Impella or balloon pump support during PCI. There is this famous PROTECT 2 trial published in 2012 of Impella 2.5 versus balloon pump. It's a negative trial for Impella, yet somehow interventionists have spun that trial to consider it a positive trial and to support the use of Impella. I totally disagree with it. So they took patients with left main disease and EF less than 35 or 3-vessel CAD with EF less than 30%. There was no difference in outcomes in the intention to treat analysis. The only time they got an improvement is on per protocol analysis at 90 days. They found an improvement of major adverse event. It was mainly an improvement of two very soft endpoints: transient hypotension during your procedure and the need for repeat revascularization because of incomplete initial revascularization. So really a negative trial with only improvement on secondary analysis of a soft endpoint. That's not saying that I don't like Impella. I just want you to be selective in your use and not just use that EF plus low EF plus left main, we need support device. Use those specific criteria, which go far beyond the EF: hemodynamics, complexity, ischemic time, guide ventricularization. Impella is likely beneficial in a very select population with high-risk PCI, like using the hemodynamic criteria and other features I defined. There will be PROTECT 4 and BCIS3 trial that will help further fine-tune which patient benefit. Also, there are 3 large retrospective analyses that show that Impella was associated with worse adjusted outcomes versus balloon pump, and in one of them, more even death than balloon pump. But those were retrospective analysis. But again, it puts doubt on the widespread use of Impella. Be selective. This is one of those retrospective analyses. Now, balloon pump trial, this is a landmark trial, BCIS1 trial. It's balloon pump versus no balloon pump in patients with low EF, in whom you're doing a PCI on one or multiple vessels supplying the majority of the myocardium. 29% of those patients were left main. There was no difference in major adverse events between balloon pump versus no balloon pump, no difference in mortality at hospital discharge or 6 months. As you'd expect, there was more procedural hypotension in the non-balloon pump arm, and bailout balloon pump was used in 12% of that non-balloon pump group. So 10 to 12% need for balloon pump and for support if you didn't use it up front. And there was more bleeding and access complication in balloon pump. Interestingly, long-term follow-up of that, at 4 years, the balloon pump arm had better mortality than the no balloon pump, but there was no mortality difference at 30 days and 6 months. So it was probably a hazard finding at 4 years. So again, no data support widespread use of balloon pump, although maybe based on the 6 months, but especially the 4 years data. Regardless, though, always when you're doing complex PCI, especially early on in your career, if you decide not to use LV support, it's always wise to put a very small sheath in the contralateral femoral artery, such as a 4 French micropuncture sheath or a 4 French micropuncture dilator. So the smallest access, have it ready. So if you decompensate, you're not struggling with access and you're ready to put your balloon pump. Also have your balloon pump or Impella console ready in your room. One additional note, when you're using Impella, it's a good practice at the end of the case to see, did Impella help me? This is how you kind of build your experience of when to use Impella. When you lose aortic pulsatility on the Impella console and on the motor current, this means that you are now fully dependent on the continuous Impella flow with very little intrinsic cardiac output, which means retrospectively that if you did not have the Impella, that patient blood pressure would have severely declined, and this may have initiated a full-blown circle of more hypotension and more hemodynamic compromise. So having, in retrospect, prolonged period of flattening of your Impella curves tells you, well, Impella helped me in that case. I want to move to another topic, which is the left main approach in general, and specifically the left main stenting technique. And I will start with this case. So 84-year-old man, exertional dyspnea and chest tightness, stable angina. His EF is normal. He has no severe valvular disease. His systolic blood pressure is 130s. His LVDP is fine, and he's not hypoxemic. This is his coronary angiogram. You see he has a critical, heavily calcified distal left main, true distal left main bifurcation, involving also the ostia of the LAD and the circumflex. There is also downstream disease in the circumflex. This is another view here. So the resolution is low here, but it was a heavily calcified distal left main involving both the LAD and the left circumflex with downstream disease. The RCA was overall okay, dominant with no obstructive disease. Those are the 5 questions we ask ourselves. And the first decision is, what bifurcation technique do I need to use? And I want to discuss those bifurcation techniques. So having a distal left main bifurcation, a true bifurcation that involves LAD and circ, does not mean you need 2 stents. This is from my bifurcation talk. If it is a simple true bifurcation, meaning both left main, LAD, and left circumflex, they are all involved, but it's a simple true bifurcation, then provisional stenting is appropriate, where you stent from left main to LAD and you just balloon the circ and provisionally stent it if it is left with residual disease over 75%. If you have a complex true bifurcation, this is where you would favor 2-stent strategy up front. And what is complex true bifurcation? Both the LAD and the left circumflex are 70% or over, as opposed to just 50 to 70%. But not just that. You can be both 70% and still be simple. You need a combination of all those 3. So over 70%, and it's long disease in that circumflex, in the branch vessel, over 10 millimeter, and other complex features. So it's a triple combination of circumflex more than 70%, long lesion, and heavy calcium or unfavorable angle, which is common because you often have a 90-degree angle in the circ, or long heavy burden in the main branch, in the LAD and left main heavy plaque burden. So a combination of all those 3 tells you it's complex, and you would favor 2-stent strategy. This particular patient was 90+%. It was long, and there was really very heavy plaque burden with an unfavorable angle. So it is what I would call complex true bifurcation. So you would favor 2-stent strategy in those cases. However, you adjust. As I said, EBC main trial showed that provisional stenting is appropriate and as good as 2-stent strategy in true distal left main bifurcation, although they mainly took simple true bifurcation. They had a subgroup of higher complexity, but they were mainly simple true bifurcation. Mainly they were short ostial circumflex stenosis. So, but still, you could consider provisional stenting in those patients if you want to simplify your procedure in a tenuous patient where you want to avoid support. And you could consider the simpler 2-stent strategy, TAP stent and T-stent instead of the crush and Culotte. So those are the 5 stenting strategy you can use in any distal left main case. Provisional, which in our case would be suboptimal but appropriate based on EBC main. TAP in a planned 2 fashion as a 2-stent strategy, DK crush Culotte, but the best technique is what I call the perfect T or nanocrush. In a lot of distal left main, maybe up to half of distal left main, this is really the best technique. So those are the 5 techniques, and I will describe that TAP and perfect T. Keep in mind an Excel trial, which is the most important left main trial, which put the left main on the map as an alternative to CABG, left main PCI as an alternative to CABG. When they did 2-stent strategy, 50% of the patient received T or TAP. Minority received the crush or Culotte. So that's why this is an important technique that I don't see widely used currently in the US. In EBC main trial, which compared the planned dual stent to provisional, and which showed they are equivalent, in a true left main bifurcation, the planned stent strategy was mostly Culotte, but they had a third with T or TAP. So that's an important technique. Only DK crush 5 trial supports DK crush in complex distal left main with many of those complex features I described. In those cases, DK crush was superior to provisional in terms of stent failure, but not in terms of mortality. But two caveats here. Provisional is still appropriate if you want to simplify your strategy. And two, for two stent strategy, no data that DK crush is superior to TAP or T or Culotte if the latter are properly done. There is no proper trial comparing DK crush to other strategy or other strategies to each other. So let me explain TAP a little bit and the perfect T, which I like very much in distal left main. So TAP is the following. You start by putting a stent from the left main to the LAD. Then you pot that left main portion of the stent. You balloon inflate it with a larger balloon, pot. Then you rewire and you place your stent. And you make your stent hang a little bit. You don't make it touch the wall. You hang it a little bit. You create a neocarina of a little bit of stent hanging in the middle of the left main. You deploy it while you have a balloon stationed in the left main LAD. And after you deploy the left circumflex stent, you inflate your LAD balloon simultaneously with the circ balloons. And this way you make sure that stent is ending up in the middle of the vessel. This technique may be used in somewhat shallow angle. You don't need to have a steep angle to use that. If you have a steep angle, you can use the technique I will describe a little later, which is the perfect T. But this can be used in shallow angle, even as shallow as 40, 30 degrees, particularly if your circumflex is small in caliber, while the left main LAD are large. The larger this is, and the smaller that is, the more you can apply TAP in shallower angles. Okay, a key idea here is that you deploy that TAP stent always after you deploy your main stent, and you have a balloon station in the main stent, ready to be inflated after you deploy your circ stent simultaneously with a balloon in the circ. You can do inverted TAP. So normally, if I do planned TAP or provisional TAP, we stent left main to LAD, then we put a TAP stent in the circ. But in cases where the circ is critical, whereas the LAD is moderate, and the LAD is easy to wire, while the circ is very hard to wire, in those cases, if you want to use TAP, it's better probably to use inverted TAP, where you put your initial stent left main to circumflex, and then you position your TAP stent in the LAD to hang in the middle of the circ, and you make a piece of that LAD stent hang in the middle of the circ, and eventually you deploy simultaneous balloon with the stent. You inflate the balloon that has been stationed from the left main to the circ. Again, you're deploying that TAP LAD stent after you deployed a main stent. And just to highlight to you the difference here in the terminology, this is a TAP stent. You have a piece of metal hanging in the middle. It doesn't touch the wall, and it's not crushed against that wall. This is different from the crush, where that stent is not hanging. That stent that would be hanging is eventually crushed against the wall. Before your main branch stent in the standard single kiss or DK crush, or after your main branch stent in what we call provisional reverse crush. But anyway, that stent is no longer hanging. It's crushed against the wall. And at one point, you'll have potentially 3 layers of stent hanging here. And this is different from Culotte, where you extend that side branch stent all the way to the main vessel, and you make it touch both edges of the vessel. Basically, the side branch stent goes all the way up and touches the opposite wall. The full circumference of the side branch stent is overlapped with the full circumference of the main branch stent. You have 2 full circumferential layers of stent against the main branch wall. So just understand the difference. In both those, you have more metal overlap. You have in this portion 3 layers of metal overlapping and 2 here. Here you have a circumferential 2 layers of stents. You have more stents overlap in those more metal than in this technique. Also notice then when you rewire with tap, here after we deploy our stent, I have to rewire. I'm rewiring only one stent layer. Whereas with those techniques, the crush and the culotte, to do your balloon inflations, you have to rewire through 2 to 3 stent layers, and you have to rewire twice. So that's why you rewire once for one stent layer in the tap technique. Review my talk about bifurcation stenting to get more details about the steps for the crush and the culotte. So I want to distinguish tap from the perfect T. Perfect T is the following. In that case, you really need to have a steep angle. I said tap, you can use it in shallower angle, but T, the perfect T, you do need to have an angle close to 90 degrees. And in that case, you plan on putting your stent exactly at the left circumflex ostium. You don't want to hang in the main vessel. This is how we do it. You position your circumflex stent exactly at the ostium without hanging. And then you deploy your main branch stent without any stent double layers. Okay, that's the perfect T. We're not crushing that stent. Then you eventually rewire and do a kissing balloon inflation. And you're rewiring across again one stent layer because here there is no overlap of stent layer in this area. So that's the perfect T. Keep in mind when we do it, we position it perfectly. Typically, I put a balloon in the left main LAD, and after I deploy the left circumflex stent, I do inflate that stationed balloon here. Why? Because in case I hang my stent a little bit in the main vessel, I want to make sure I crush that portion. It will be crushed by my balloon and eventually by my stent. The idea here with the current technology of stent boosts, you can try to aim for perfect positioning. But the truth is perfect T and nanocrush are kind of similar technique, can never be perfectly certain. So when I say perfect T, it's different from tap, but it's very simple to nanocrush. Nanocrush means that I have made my stent hang a little bit in the left main, mostly inadvertently. I have made it hang a little bit in the left main, and I've crushed that little bit, usually 0.5 millimeter or less. I've crushed it against the wall, but it's such a little amount that nanocrush and the perfect T are practically similar strategy. This is the perfect T. You have absolutely no stent portion being crushed against the wall, and this is the nanocrush. You have a tiny, tiny area here being crushed against the wall, but most of that area is just single stent layer, that red stent. For that reason, perfect T is almost a nanocrush. We can use those terms interchangeably, and we apply that technique to the 90-degree angle. This is different from the standard crush, whether standard single kiss or double kiss crush, where you have a larger portion of stent being crushed and more metal layer overlap. If you crush in the perfect T, you're probably just crushing a couple of struts. You're not having a full-blown crush layer of stent across the circumflex. And the important thing in nanocrush, like in perfect T, you still only need to recross once, and it's much easier to recross than the true mini crush, which has a much longer crushed area. Okay? So to go back to the 5 questions in our patient. First question, does he need atherectomy? Yes. Heavy calcium. I would favor not lithotripsy. When do we decide lithotripsy versus atherectomy? When you have severely calcified and severely tight lesion, it's hard to consider lithotripsy up front because you will not be able to advance the lithotripsy balloon. You will need to advance a balloon, try to dilate the vessel before you can put lithotripsy. Also, lithotripsy, in my experience, is less tolerated hemodynamically than rotablation because you have to inflate that balloon multiple times for 10 seconds each time. So it may be less tolerated than short runs of rotablation. The second question, left main bifurcation technique, this is a 90-degree angle or close to, I would favor perfect T nanocrush. You can do planned tap, where you send from main to LAD, then rewire and do tap of the circumflex. I don't favor that. The best is perfect T nanocrush. The third technique will be decrush, then it will be Culotte. Does he have distal disease that needs to be treated? He has circumflex disease, but it's not absolutely necessary to fix it, as I will show in a little bit. And that will increase your hemodynamic complexity if you try to fix it. A sedation plan, I would use anesthesia support with deep sedation and high flow O2. Do we need LV support? Based on the 2 major and 6 additional features, in my opinion, not. I would put a contralateral small femoral micropuncture sheath, maybe balloon pump, and these are the idea. He's stable hemodynamically. Complexity, it is complex, but I'm simplifying it. I'm going to use a perfect T nanocrush with less steps. He doesn't have any of the other risk factor, no RCA disease, his EF is normal. I don't expect guide ventricularization. So for that reason, I favor no support. Now, to show you the subjectivity here, this was done by my colleague, and he chose to use Impella. Again, there is subjectivity involved, but in my opinion, this wasn't necessary. So they did rotablation in this case, and they did eventually a perfect T strategy. But here is what they did also, and they decided to fix that circumflex. And it is hard, and they tried to fix it, evidently distal disease, they wanted to fix it before they put metal in the left main. And this is where they got into hemodynamic trouble. It was difficult to advance that stent in the circ across the calcified left main. So they had to put a guide liner through the left main into the circ. They had to do a lot of maneuver to deploy a stent in the circ. And in that process, they caused ventricularization of the guide and the guide liner, and they caused left main ischemia, prolonged left main ischemia. And this is the time when their Impella pressure became flat for a significant period of time. They even needed to use neosynephrine on top of it. The only time the Impella became flat and neosynephrine was needed is during that circ stent and during guide ventricularization and left main, prolonged left main ischemia. Again, there is nothing worse than that guide ventricularization. Try to avoid it. In this 84-year-old man with stable angina, I really would have myself avoided that circ. And as a result, I would have actually avoided support, because this is the only time, interestingly, where you need support. And this is the less important part of our intervention. So after doing this, this is the perfect T. You can see they position the stent here, and you can use a stent boost to make it more perfect. Here it was probably more a nanocrush than a perfect T. And you can see here how it's positioned. They deploy the stent while having a balloon ready to crush that stent in case you have a nano micro portion hanging. So they deploy the balloon eventually. Then they deploy the left main stent, then we do part of the left main stent, and we rewire through one stent layer. That's the beauty of a perfect T or nanocrush. Or if you had done also tap, we only recross once through one stent layer, and we do kissing balloon inflation. And the way we do kiss, the standard technique for kiss is sequential kiss. So you do high pressure inflation of each balloon sequentially, particularly in that circ. You want to do high pressure 16 to 18 atmosphere because the ostium of the circ is always the site of the worst stent expansion and most restenosis in those cases. So you do sequential high pressure balloon inflation, then you do simultaneous kiss, usually at 10 to 12 atmosphere. And they got eventually a very good result. But the toughest step, the lengthiest step, with the most hemodynamic effect was stenting the mid-circumflex. That's how planning those cases is very important. Think of, they interact those questions. Needing support depended here on that you wanted to treat the distal disease, and could have depended on, I want to use decrush, and could have depended on, I wanted to keep my guide ventricularized off and on for a prolonged period. So you take into account all those features, and could have depended on maybe I needed to intubate this patient and wanted deeper sedation for intubation. So take into account all those factors. I will stop here, and I plan on giving a second part to this talk where I show more cases and more decision-making regarding how to stent the distal left main, what strategies, and when to decide about using LV support.